On behalf of the Partnership to Fight Infectious Diseases, my name is Kevin Alderson from Boston University. Welcome to today's webinar, in which we're going to focus on how antimicrobial resistance and pandemic preparedness work together. And I have to say that there's folks on this webinar from all around the world. So good morning to some of you on the East Coast, and good afternoon to those in Europe. Good evening to people in Asia. And for those who are somehow calling in from California, we doubt your sanity because it's very early in the morning for you, but thank you for joining us. AMR is indeed a global problem, and so I'm not surprised that we have a global audience and global panels to discuss this issue today. And I have to say that when we talk about preparedness, everyone thinks obviously about our experience this last year and a half with COVID. But I have to say that we also have to worry about other pandemics. We don't want to design an entire preparedness infrastructure to fight the last war. If you look at the tree of life, how biologists have organized all of known life into a single diagram, really, our historic foes, the things that like to compete for life and therefore kill and eat us, are the bacteria and the fungi. These are folks that we need to worry about. And antimicrobial resistance, the folks that you'll hear from in the panels today, we've been talking and writing and thinking and working on this issue for years. It's a different sort of preparedness than what we've had to do against COVID. But nevertheless, it's important. And it's important that as we're doing everything we can to get the world out of the crisis with COVID-19, that we also make sure that we're ready for the other things that we know are coming. A little bit of prevention now will yield great benefits in the future. So it's my honor to welcome you and to introduce our first panel. We have two excellent panels. The first four panelists, we'll start with Professor Dame Sally Davies, who many of you will know. She's the UK Special Envoy for Antimicrobial Resistance. She's a member of the Global Leaders Group on AMR. With the blessing of the Queen, she became the very first woman to be appointed the Master of Trinity College, Cambridge, in its long history. She previously served as the Chief Medical Officer for England for many years. She's been a tireless advocate on all things AMR, and we're grateful to have you with us today. Our second panelist, Professor Dr. Veronika von Messling. She's the Director General of the Life Science Division at the German Federal Ministry of Education and Research. Prior to that, she was head of the Veterinary Medicine Division at Paul-Ehrlich Institute. Her experience lies in the development of novel prophylactic and therapeutic strategies against infectious diseases. Our third professor, fourth counting me, I guess, Professor Ken Ishii, is a professor in the Division of Vaccine Sciences in the Department of Microbiology and Immunology, and is the director of the International Research and Development Center for Mucosal Vaccines at the University of Tokyo's Institute of Medical Science. He is a member of the Partnership to Fight Infectious Disease AMR Task Force Advisory Board, and is a leader on many projects with many things focused on biomedical innovation and vaccine science. And last but not least, but Michael, I think the only one without a professor title on this crew so far, maybe we can work something out for you. He's the Senior Advisor for Antimicrobial Resistance in the Antibiotic Resistance Coordination and Strategy Unit at the CDC, the Centers for Disease Control and Prevention in Atlanta, where he works closely with leadership within the U.S. Department of Health and Human Services, and really with colleagues around the world to align these public health activities related to AMR, both in the United States and globally. We have a real opportunity. There's a lot of legislation that's moving about. We have the pilot program in the United Kingdom that maybe Dame Sally can talk more about. We have a very exciting European strategy document and process within the European Commission for evaluating antimicrobial pull incentives as a way to prepare for the next crisis. In the US, we have the PASTEUR Act, strong bipartisan support, as well as other pieces of legislation like the Superbugs Act that really focuses almost entirely on making sure that whatever the US does in this area is coordinated with other countries, a very thoughtful proposition. So with that little bit of scene setting, my first question for the panel, we it's the media, it's also maybe just the way that we react to these things, but we've heard so many negative stories about pandemic preparedness, everything we've done wrong. And so I'm wondering from the panel, are there things that you can talk to us about in which, the world has actually done something well, has done something right in pandemic preparedness? Is there a lesson learned that isn't getting the airtime it deserves, that we actually did get some things right, and that we can build on that, not only for pandemic preparedness generally, but specifically for antimicrobial resistance? So any of our four panelists, take it away. I see Beam Sally has her hand up.
So let's start with vaccines. We all know that we've done really well on vaccines. And the point I would very much like to highlight about vaccines is that, of course, they were built on pre-existing research. The mRNA ones on pre-existing research for cancer vaccines. And then the other thing that one would have to say is that not only was the basis of research in Britain, we've used ODA, aid funding for the Oxford group to develop that ChAdOx1 vaccine for MERS, but then having the scientists pivot to make COVID vaccines, their partnerships with major pharma companies to make sure there was effective manufacturing and the possibility of distribution, and we can all cheer to that. I'm happy to go on, but perhaps others would like to come in first.
I see Veronica's hand up, and I'm sorry, I was a little slow to look at the hands up on the right. So, Dr. Van Messling.
Yeah, I couldn't agree more. The vaccines, I think we see how technologies that weren't meant for this, or that hadn't been developed for this particular goal, come out as winners, and others that we expected to be the front runners turned out to maybe be a little slow out of the gate, or maybe not so suited. And I think it shows very strongly that investing broadly in different aspects of fundamental research, that is what paid off big time. I think the other thing that really paid off was the modeling, that people who were before doing, let's say, weather forecasts or other things, were able to quickly apply their expertise to this problem. And I think maybe as a more global view, it really shows that humankind, when faced with such a challenge, lives up to it. And I think it gives confidence that we are also able to solve other problems if we put our minds to it. And I think that's very inspiring. And so the question is, how can we harness this creative energy and also the dropping of certain barriers in a way that allows us to use this not just in an emergency, but also in, let's say, slow moving emergencies, like maybe AMR or other situations that are not as dramatic immediately as this one was. Thank you.
Those are both excellent points. The unsung heroes here are the governments who funded basic research 20 years ago that led to the platform of messenger RNA. And we should dig out the records and find out here all of that basic science work was essential. There's a slide going around. I don't have it. It's not mine. But it's designed to puncture the myth that to illustrate the foundation on which the vaccines were built, and how many years it took to be at the position we were at, and how grateful we are that all that foundational work was done. Michael Craig, see your hand up.
Thanks, Kevin. And I would just echo and actually maybe put it more succinctly, or more broadly rather, of we got what we paid for. And I think that that's true across the board and across a lot of different countries. If we invested in something, or if a country invested in a capacity in advance of the pandemic, that capacity was ready during the pandemic. So we were prepared in that sense. And I think a lot of the things that we underestimate is that public health, preparedness, prevention, all of these things are a form of insurance. And like a lot of types of insurance, people walk around with not enough. And they only realize it when they need it. And so, in the US experience, in addition to the points made on vaccines, I would highlight that we've invested in the last decade in terms of improving patient safety and infection control practices, especially in hospitals. And we've seen that paid off during the pandemic. We have not seen COVID transmission widespread in hospitals or because of poor infection control practices in hospitals. But in those areas that we didn't invest in or put in the same type of emphasis or support in the same way, areas like long-term care or nursing homes, we did see problems. So I think one of the things that we fundamentally need to wrap our heads around, not just in the United States, but around the world, is that prevention is preparedness, and that we're never going to be able to address an emerging or a novel threat if we can't effectively deal with a routine or current threat, an endemic threat. And I think antibiotic resistance is the best example of that. If we can't fundamentally get ahead of it now, or in a time when we don't have a pandemic, when those crises come along, no amount of planning is going to get us there. So we have to do things today, and we have to invest in things today so that we have them tomorrow.
And Dr. Ishii, I see your hand is up.
Sure. This is Kenichi from the Far East Asia in Japan. And one more things that I can add on to this discussion is that we really had underestimated was hygiene and education for that. So that whenever we see people in Japan wearing a mask before COVID-19, people are laughing at because they were probably only allergic to pollen. Now that habit has helped a lot to prevent this infection more than COVID-19. Rather, we could prevent many other diseases, including other hygienic disease. So that in addition to vaccine, I would stress on this importance of hygiene and its education.
Yeah, just to group together some of the threads from those last two comments. It's one thing to have a vaccine against a very specific threat that you think is going to come. It's a very narrow spectrum response, and it's difficult to know exactly what's coming. And so the broader, deeper research that Dr. Van Messling talked about is necessary. But Michael Craig's point, I think, correct me if I'm wrong, is that if we have well-prepared health systems, if we have well-trained, well-staffed, defense in depth in the health system, we'll be ready for whatever infectious disease, or more ready for whatever infectious disease threat comes. It's a broad spectrum defense in a sense, just like the ability for the public to be educated, for public hygiene, hand hygiene, and social distancing. All of these are broad spectrum. They can work against any type of threat while we wait for the final, months and years worth of work to be done on the narrow spectrum response. It's interesting, this layered defense, having something that protects the whole health system, but then having a very specific response. And I'm interested in how this works specifically for antimicrobial resistance, because there obviously were programs in hospitals and around the world, and especially in higher income countries that can afford to give significant resources to this. But it's my understanding, and maybe you can correct me, that many of these programs kind of got set aside during the COVID, crunch, that we've actually had changes in the way that the antibacterial resistance has expressed itself in hospitals because everyone is so busy with COVID. And so I'm wondering if any of the panelists can speak to that.
Yeah, I'm happy to jump in there, Kevin, and would agree in part. I think that the thing that I would tweak in your statement slightly is that those programs didn't get set aside. Those programs had to be redirected. So we have antibiotic stewardship programs, we have infection control programs, and they've been focused on those routine threats. They had to pivot for the pandemic. So a lot of our pharmacists who are working in hospitals weren't looking at the antibiotic prescribing as much. They were looking at how best to deliver vaccines and make sure folks were vaccinated. They were looking at the monoclonals and all the things that were underdeveloped and making sure that their hospital had enough to be able to address the patient population that was coming in, which is, surged in different times. And so if those folks had not been in there and we hadn't invested in there, we would be in a much worse position. And likewise, on the infection control side, the infection control really pivoted to addressing the pandemic and focusing on that. And some of the challenges that have arisen have been because our health systems, while they were prepared, they were stretched and they were not as resilient. So you're right, we have seen for routine infections, the things that we were dealing with day to day before the pandemic, those have increased in hospitals, including those things like MRSA, MRSA, and other antibiotic resistant threats that we were preventing effectively before the pandemic. We've seen a reversal in that prevention, unfortunately. And I think that goes to, we have to build the capacity, we have to build the know-how to do these things, but we also have to build resilience so that we can do more than one thing at a time, because that's what is going to be demanded of us during a pandemic.
And
so I would pick up on the fact that we fund 24 countries through the Fleming Fund to develop their laboratories and surveillance. And most of that continued, but some of it pivoted. And for instance, in South Africa, the genomics part of it picked up the beta variant and was able to do that. So I think it is about prevention, but there's no doubt that stewardship has suffered during COVID. The data about prescribing in hospitals and in communities is quite scary about how it's gone up. So we need long-term surveillance, and we need enough backbone that while we pivot, we don't lose the things that are there. The thing that we haven't mentioned yet that I think is quite important in this about what's there longer term is data. How can we take action if we don't have data? And I absolutely agreed with Veronica's comment about the modeling, but we also saw, and it picks up on that previous investment, modelers from other areas coming in, and that was helpful, but they didn't have behavioral data. We saw companies coming in, Google, Microsoft, others sharing anonymized data, but allowing it to be used, particularly about behavioral issues, in order to help direct policy responses. I was very worried about the data lack, and I set up the Trinity Challenge, and people were generous enough to give me £7.2 million, $10 million. And we got 340 applications about how you could use data better to prevent pandemics or manage them better from 62 countries. And the grand prize winner is just perfect for AMR. It's participatory One Health disease detection, PODD, from Thailand, where they give frontline farmers, so here I am on AMR going into One Health, they're making them disease detectives by giving them mobile phones to take pictures of their sick or dead animals, which go to vets who can then give them advice, support, diagnostics as necessary, and then join that up with the human data to look for spillover and crossover. And with our prize, they're going to expand into Indonesia, Vietnam, Laos, and Uganda. But we didn't have the data systems, the broader data systems involving behavioral data we needed. And we're going to need much more behavioral data to manage AMR effectively.
And I was going to ask for similar experiences from Germany or Japan, and I see Veronica has her hand up.
Yeah, I think that touches at an other point, which is that we realize how important it is to have data, and actually not just the models. I always say the one thing is a weather forecast, the other thing is that it rains, you know, and so it's a bit the same thing here. But that's a huge opportunity as we collect these data, and these days we are able to collect them much more unbiased than we ever were in the past. It allows us to mine these data for AMR, but it also for other possible infectious disease threats, or even other aspects of, let's say, public health or safety, and that opportunity, there's no competition. I think we don't want to have a situation where we say it's either pandemic preparedness or it's AMR or it's something else, but rather here's an opportunity to say, if we improve the data that we collect here, if we improve if we have a net with smaller holes in it, if we have more information, then we can use this to address all kinds of challenges and answer all kinds of questions. And of course, it always comes with the justified fear that then we have this see-through human, and there is no, it could be abused, and it can be abused. But I think the pandemic is like a looking glass, and it helps us to focus that not doing it also has a price, and that we have to really work to find ways to use this for responsible use, and not say, oh, we better don't do it because who knows if it's going to be abused. And I think that's a huge opportunity that the pandemic offers to us, and it is up to us to use it, and that will benefit public health and many other aspects in general, and especially AMR, because a lot of AMR is also not knowing or not believing the data. And so I think those two things can be helped with good analysis of real-time data.
Kanishi?
Sure. I'm not sure whether I'm really following this conversation, but what was happening in our own country was that, of course, as everybody said, AMR is a slow pandemic. The real pandemic revealed everything that as AMR was human-made, but also pandemic fear was human-made. So that I was telling to the people in Japan that people are scared of many drugs or vaccines, like vaccine hesitancy. So the two proverbs were always in my mind. One was haste makes waste. So if you are too much in a hurry, you always makes a problem. But it didn't happen in the vaccine development to this pandemic. It was very enormous effort and then a victory and then even triumph. On the other hand, why people rush into this vaccine and drug development and development of the diagnostic. So there's another proverb came into my mind: fools rush in where angels fear to tread. So that people didn't mind making a big failure, but challenged to make a diagnostic, vaccine, and even the treatment drugs, or even the new type of masks, for example. So that challenge by young people in new field would have actually had made a lot of advanced and innovative products. So we learned a lot from the pandemic, and then that probably will make many feedback to this combat against AMR.
Yeah, I have to say, sitting in Boston, we can focus a lot on the biotech companies here trying to make a wonderful new product, and Moderna would be one. But an amazing, resource that different countries had a better experience than others is the trust that the population has in the public health infrastructure and the responsiveness. Does the public socially distance? Did they quarantine? Do they mask up? Are they being careful? Are they doing hand hygiene? You know, trust is a very valuable resource to a country, trust in the public health system. And for some countries, this is a good story through this pandemic. For others, more of a mixed bag, right? Is there anything that we can do to heighten or to build and to earn that trust from the public in this issue, preparedness for AMR? Michael Craig's going to jump in on that.
Well, just jumping in there, Kevin, I think one of the things is that we have to be present all the time. It's not just during the crisis. And I think that this gets at how do we measure preparedness? And I think for a long time leading up to the pandemic, it was measured more by how many tabletop exercises you did, or how many hypothetical things that you did to prepare, or how many plans you had on paper. And I think we have to get out of that mindset. And I think we have to get into a mindset of how are we dealing with the current problems we have, our everyday infectious disease threats and those problems like antibiotic resistance. Because if we can't deal with those in a normal time, we're not going to be prepared. There's no amount of planning that will prepare us. And likewise, if we have trouble getting people to get vaccinated for a routine vaccination, we should have no surprise when a pandemic comes around that we have trouble getting them vaccinated for something else. So the more present and the stronger public health is during a regular time, that is going to be, I think, a better model of what is true preparedness, and how we, the data we collect and the data that we're tracking about our current threats and how we're preventing those threats and how we're responding, I think is a better measure ultimately of our preparedness and our resilience than any amount of plans that we have on paper or any amount of other engagement. And I think in turn, that's going to help us have and cultivate trust when real problems or when acute problems like pandemics come around.
Veronica, then Sally.
Yeah, let me add a different thought, and that is, I think the pandemic has demonstrated the systemic issues that we also have in the area of developing new antibiotics. AMR is more than that, and I think we've talked about the aspects of hygiene and prevention, but then there's also the aspect of developing new weapons for our arsenal. And there, I think, I remember our discussions about push and pull incentives and all this. And I think the pandemic is a really helpful and incredibly strong demonstration of what that actually means. And I think the discussion that we now have about pandemic preparedness that go along the lines of, let's say, natural disaster insurance, right? And the question always is, which plan do we buy? How much do we want to afford? And what do we buy? What is going to be part of the package? And there, I think the strategic framework that we have for AMR is incredibly helpful in the discussions about the pandemic preparedness, but vice versa, when we talk about antibiotics development, I think we have now seen what it means to have a pull incentive, and what it means to have a push incentive. When we think about the vaccine development, that story, or even the drug development, which was maybe is equally impressive, but maybe not as much in the public eye. And I think the discussion we have to have is the discussion that we've tried to have for antibiotics for a long time, which is if public funds are used to develop a product along the development line, so the de-risking is covered by public funds, then the pricing and the management, the use of the final product there's a different discussion to be had than it is to be had when we have a classic pharmaceutical development. And I think I know I'm preaching to the choir, but I find it particularly inspiring to see that situation right now, because it just demonstrates what that means. And also what the different stakeholders, what is the role? What's the role of the pharmaceutical industry? What's the role of, let's say, government-funded research and development? And then what is the role of the entities that later market these things or produce them and market them? And all of a sudden there's new players that enter that field. And I think we have to take advantage of that right now, to not just to deal with it or to address it in the context of pandemic preparedness, but to include the discussion of antibiotics development in that conversation, so that we make sure that it's not left aside or left out. Thank you.
Veronica, before Dame Sally comes in, if I could, ask you back, what you're talking about with pool incentives sounds like, the subscription that, the countries get access to it with, conditions on delivering it, et cetera, and the price is prepaid in a subscription. Can you say anything, Veronica, about what you're hoping the European Commission does, what Europe does on antibiotic or antimicrobial pool incentives?
Oh, I think that's very much up for discussion still. So I can't say anything specific. I'm sorry.
I can't trick you into saying something.
No, yeah, you can't. But what I can say is I think that the discussions are changing, and I think we have to take part in them and make sure that we contribute to this design of these structures, so that we make sure we get maximum benefit out of it for the people who need it.
Right. And one of the points you made is that this is not a theoretical thing that might work. We know from COVID how this thing does work. And so it's no longer just an academic paper or an idea. It's a real practical alternative for us, if that's a fair restatement. Sally, and folks, feel free to jump in too. I know you've been raising hands, you've been really polite, but if you feel like you've got something, jump in. But Sally was next.
So I absolutely agree with Veronica. And I think to extend one bit of her conversation, which is we've seen in COVID that prevention is much, much cheaper than cure. And that really has had an impact on the finance ministers of the G7, who are meeting once a month at the moment, discussing pull incentives and innovative funding. So let us hope that between us and Germany, who take over the chairmanship, that moves through to pull mechanisms that work across the world. But you raised the issue of trust, Kevin, and I thought that we shouldn't let that pass without addressing it. We are in a time where people are losing trust in their governments. And if you've got a weak trust level for a variety of reasons, then how do you build it? And interestingly, whenever the annual survey is done in Britain of who do the public trust, they trust nurses and doctors top of the pile. So we have to use in our communication, and Dr. Fauci was wonderful in the States, the people that do have the trust and help them to build it even more. And it's nurses, doctors, and of course, scientists at a slightly lower level. But that raises quite an interesting question, at least in Britain, because there are a number of nurses who are anti-vaccine. And so you also have to remember that they are the holders of trust from the public. How do we educate them and take them with us? And this isn't done overnight. This is a slow, steady process. And we all know the behavioral work about how you have to listen to what they think is the problem and then take them through it and then ask them whether they've understood and build it very slowly. Important to do. And I just didn't want trust to pass without comment, but happy to go back to pull incentives or anything.
Can you end the jump in?
Yeah, following this discussion about trust, one thing that we learned from this COVID-19 pandemic, especially for the development of vaccine and new treatment, was the transparency of the data sharing among the airlines, and then the big clinical trial based on the transparent rules, and then communication to change and modify that clinical trial rules. But during all this procedure was so transparent, and then even regulations discussions were all online in YouTube. So this was completely different from the previous time, that this transparency of process and data sharing made us trust, especially those products came from the Western airline countries of alliance, and that's why we are very thankful to UK, Germany, US for us to purchase the very effective vaccine to save us in the world in Japan, especially to conduct the Olympic very safely. And I just like to thank you using this moment.
I think it's really exciting that, as Veronica said, we have actually an example now of a solution for this problem of preparedness for antimicrobial resistance. We understand how push and pull incentives can work here. We have an actual living, breathing example of it. I don't even want to call it the pilot anymore because it's operational in the United Kingdom with 2 antibiotic drugs entering into the system and being paid for based on the value to society, not just the volume of pills sold. A beautiful delinkage subscription. We see the Pasteur Act in the United States, which is a U.S. version of the same idea. We see a very deliberate process underway in the European Commission, which may well take more than a year to come to the end of a vice process, or maybe longer, but still, a serious effort. I've been aware of some discussions in Japan, and then obviously the G7. It's been a major thing that the United Kingdom has championed. The next chairmanship goes to Germany, and I believe after that Japan, if I'm not mistaken. So we have about 5 minutes left, and as we make this transition from pandemic COVID to endemic COVID, and we learn to live with it, in a sense over time, it becomes a little more like the what we've been living with antimicrobial resistance, and I'm just concerned, whether we have the right combination of energy and the right message for policymakers and the right message for the public, so that we can get these pieces of legislation, these pull incentives that we think are necessary. How do we get them across the finish line in these countries? So we have about 5 minutes, and just jump in. Don't bother to raise your hand.
Well, we're going to have to do a lot of work, aren't we? Because we want to keep, for instance, in Britain, the system that I set up, a clinical trials infrastructure that's worked well for COVID, and pivot it so that it picks up many more anti-infective approaches too. But we know that antibiotics have been overused in COVID, so we've got to rediscover stewardship in the light of COVID and think through how can we work with people on that. But even that isn't enough. We're going to need much more innovation in can we get vaccines that prevent people in hospital catching a bacterial disease and save antibiotics. I mean, pneumococcal vaccine prevents infections and save antibiotics. Flu vaccines save. What more can we do that we can help? Can we think about vaccines for patients who are going to have cold surgery, planned surgery that will protect them against the infections they might get? We need to make sure that we've addressed the behavioral issues of patients and potential patients. And I think there's going to need to be a terrific amount of learning and cooperation across different systems and across the world if we're going to get this right.
I think Dame Sally's comments are fantastic there. And I would just echo and magnify a couple things. I think that, when we're talking about policymakers about these opportunities for antibiotic resistance, I think we need to point to the pandemic. And I think we need to really illustrate the fact that antibiotic resistance, antimicrobial resistance is a very complicated problem. And it is very akin to what we're dealing with right now. And so we have to invest in preventatives like vaccines or decolonizing agents. We have to invest in new drugs and treatments like we have with monoclonal antibodies and other things for COVID. We have to invest in our public health workforce in prevention so that they are ready there. And I will, reiterate once more that I think probably the best measure of our preparedness is how we're dealing with our current threats. And antibiotic resistance, I think how a country deals with antibiotic resistance, its ability to improve stewardship, its ability to direct infection prevention and control, its ability to make sure treatments are available and working. All of these things are what we deal with every day for antibiotic resistance. So if a country can address antibiotic resistance, I think that is a great measure of its level of potential preparedness for a new emerging threat and a novel threat.
Maybe I can add from a research perspective that the antibiotic resistance the research questions that arise from that particular problem have a lot of common ground with the research questions we have, and we talk about unknown emerging threats. Here, it's a known emerging threat, but it allows us to use this as a starting point and as a basis to develop the processes that we need for unknown threats, and in that process, develop urgently needed approaches to address the AMR related problems. So that's why I think it is really good to discuss this proactively in the context of pandemic preparedness, because I think there's a lot of synergy and a lot of things learned from what we're doing here, and also a possibility to measure what might be successful and what might not be successful as the AMR situation is a real situation that is actually ongoing. So there's much more to be learned from than we do at the moment. And I think positioning it that way might also garner a lot of support from stakeholders or partners that haven't seen themselves in that area previously.
So just let me jump in just for a moment, for 1 minute. I totally agree with you all, and suggesting that the prevention is far more important than, do you hear me? Yeah. And with the vaccine, it's far more important than anything else. And we can do it even after something occurred, meaning that we need to really invest, not only the vaccine, but also some other alternative to invest for the prevention and as a preparedness. And for that, I would like to emphasize like a phage therapy or new anti-infective. It's affordable, and it should be spent more than ever for the or investment for the preparedness, rather than spending money just for the drug, for the treatment.
So I want to thank the panel for all their insights. It is indeed a global problem. We're grateful for these global voices today, on this panel. We, I look at this problem, and there's we have to be realistic. I mean, this is science-based and trying to get humanity to move forward collectively, for us to work together, learn together. But I have to be optimistic that we can learn from what we've experienced. We can do better. I think that's a strong human impulse. And with antimicrobial resistance, this is, like Veronica said, this is a known threat. This is not an unknown disease X. We know this is there. We know it's an impact. We know it will grow. We understand the direction of bacterial and fungal evolution. It's not in our favor. And we have lessons that we can pick up and move forward. So thank you so much for your time. We're going to transition to the second panel, but first I'll introduce Dr. Ken Thorpe, who's a professor, yet another professor from Emory University, who leads the Partnership to Fight Infectious Diseases and the Partnership to Fight Chronic Diseases. So Ken.
Thanks. Thank you so much, Kevin. So we're here at halftime. So good morning, good afternoon, and good evening. So I'm Ken Thorpe, an advisory board member for PFID and chair of the Partnership to Fight Chronic Disease. I just wanted to thank all of you for joining us today. That was a wonderful discussion that we just had. And I love the international perspectives on this. We knew it before, and of course, COVID-19 has highlighted that among those who are most at risk for serious illness or death from infectious disease are those living with chronic conditions. So I've been doing some work looking at the likelihood of a hospital admission or ICU use among COVID patients. And it's about 5 to 6 times higher among patients that have one or more chronic healthcare conditions. So the interaction between these two issues of chronic disease and infectious disease is very real. For this reason, our group, the Partnership to Fight Chronic Disease, has been working to engage the chronic disease community in these types of conversations around infectious disease and the threat of antimicrobial resistance. We're seeing increasing vulnerabilities for people living with one or more of these conditions. Just last month, our moderator here today, Kevin Utterson, and 2 other PFID advisors, Helen Boucher and Amanda Jessic, among others, other infectious disease colleagues, authored a paper in the American Cancer Society journal highlighting that infection is the #2 cause of death among cancer patients. So just to put that in perspective, the NCI reported that in 2020, an estimated 1.8 million new cases of cancer would be diagnosed in the US alone, and 606,000 people would die from the disease. Now, when you consider those numbers, it's impossible to decide that the time is now to take action against the infection. The public agrees. The Partnership to Fight Infectious Disease has conducted public opinion research that 7 in 10 voters say that developing new antibiotics to combat resistant bacteria should be a high or top priority. About 80% of these voters also support pandemic preparedness efforts and say it should be an important priority for the Congress. We know that the policymakers, like all of us, are concerned not only about responding to COVID, but also ensuring that we're not caught unprepared, again, for future health threats, a major part of what we just was discussing. Yes, we can't look back, but we've got to figure out a way to be more agile going forward in anticipating future pandemics. While many of us here see this conversation as long overdue, it's encouraging to hear that the broader public agrees that the time is right for action. As we see it, there are 2 major challenges. One, as resistance grows, the pipeline for novel antibiotics is grim. Fewer are investing in diagnostics and development of new antibiotics. 2, domestic and international action is needed now to address the AMR threat, support the development of new treatments, and make needed investments in prevention, detection, and surveillance. So alongside with our partners and advisors, the Partnership to Fight Infectious Disease stands committed to support efforts to address AMR threats. We welcome others to join us in this important pursuit. And again, we thank all of you for joining us for today's important discussions. And I look forward to our second panel. And again, thank Kevin for a wonderful job you did in the first panel, and we look forward to the second one.
All right, so I guess the first panel went well. I'm asked to do another one. Is that what's happening, Ken? All right, so thank you.
Absolutely.
We're now transitioning, to our second panel. Again, a tremendous group of people here to share some of their insights with us, and we're going to be thinking, in the second panel, about the international efforts that we have underway on pandemic preparedness, how they're shaping up, what we can expect in the future, and how the various stakeholders are already obviously moving on both pandemic preparedness as well as antimicrobial resistance as well. What's underway, what's happening, what are the steps that are moving that are important to us. So our 3 panelists for this next group. We'll start with Julie Gerberding. She's a medical doctor and PH. She's the Chief Patient Officer and Executive Vice President for Population Health and Sustainability at Merck. And there she's responsible for patient engagement and corporate social responsibility, ESG, and other functions. But we also know her distinguished record of government service, including her prior role as the former head of the Centers for Disease Control and Prevention. Secondly, we have Esther Krofa. She's the executive director of Fasta Cures at the Center for Health for Public Health at the Milken Institute. She has a lot of experience in government, nonprofit, and for-profit sectors, and she's led many efforts to bring diverse stakeholder groups together to solve critical social issues. We're really grateful to have you here with us today, Esther. And then third, Monique Mansoura. She's Executive Director of Global Health Security and Biotechnology at the MITRE Corporation, where she has a focus on the sustainability of biodefense industrial base and public-private partnerships that are vital to the national and global health security as well as bioeconomy. She's internationally recognized as an executive in the biopharma industry and the biomedical research and development ecosystem. And just to note that there's experience and representation there from the corporate world, from the government side, from social engagement with civil society, as well as nonprofit corporations. Okay, so terrific panel. And just to start, many of the solutions, and I should say, there's 3 panelists here, so maybe you can just jump in and we'll try it without hands for this panel, and you can just speak up when you're ready. But many of the solutions that we've had to COVID have required innovation and sometimes really at breakneck speed, as we saw with the messenger RNA virus vaccines. But most of that was built on lots of success and work in prior decades that was not specific to coronaviruses, that was really broad. But what can we do and what are we doing now to ensure a more sustainable preparedness ecosystem broadly so that we're better prepared for whatever evolution throws at us in the near future?
So thanks, Kevin. And I can start just to get the ball rolling here. I think the good news is that science is on our side. If you look back over the COVID pandemic, there are at least 830 different compounds in various stages of clinical development around the world, including vaccines, antivirals, immunologics, diagnostics, et cetera. That's really unprecedented. And really, I think a sign that not only do we have a vibrant ecosystem of innovation, but we have the technical and the scientific foundations to do things much faster than we did them in 2003 when the first new coronavirus emerged. So that's all great. And we need to preserve and treasure and protect that opportunity on a global basis. I'm not so sure society is on our side. And that's really where we have to drive for a common understanding and awareness of how serious these threats really are, not just in terms of the impact of the infectious disease, but all of the collateral damage, the economic damage, as Ken was pointing out, the chronic disease implications, and on and on and on. The other aspect, of course, is just broadly our willingness as a society to not only invest in the preparedness efforts per se, but in the foundational issues that are actually driving the emergence and spillover of infectious diseases, at least from natural sources. So there is ample opportunity. And my main message here is that the scale of our thinking needs to change. We're facing a multi-trillion-dollar challenge with COVID, and we're talking about millions of dollars of solutions. And we really have to scale our investment in predicting, preparing, preempting these kinds of problems to a level that's more commensurate with the degree of threat that has now made itself painfully clear around the world.
Yeah, and I'm happy to jump in to build off of those comments, Julie, as well, which were fantastic. What we have seen during COVID-19 is a catalytic moment. One, it cemented, I think, in the public, the significant importance of investment in public health infrastructure and institutions. And that has galvanized, I would say, the global health community to think about what do we need to put in place now to prepare us better for the future. We saw during COVID-19 that a lot of countries did not have lab capacity to conduct PCR tests. We've had a number of conversations with different countries that sent samples to reference labs in other countries at the beginning of the pandemic. And now here, 18 months later, they've built that capacity, 100, 200 labs in country that can do PCR grade testing. So that capacity has certainly been developed and built, but we need more than that, obviously. We need a broad approach to pandemic preparedness that takes that One Health approach. It's not just about our health systems, which are quite important as well, but thinking about the total systems where there's a likelihood for spillover events, either in zoonotic populations or in animal and agriculture, that we're thinking about this holistically. But that requires a significant level of investment, but also within country coordination and then outside of country coordination at the regional global levels. And we're certainly seeing a lot of initiatives are being announced. In the earlier panel, Dame Sally Davis talked about the Trinity Challenge, which has moved toward approaches that could help bring together this One Health mindset, but it's certainly more is needed. We have to balance that, of course, with dealing with the current pandemic, but it's not building on today's infrastructure, it's taking today's infrastructure and building it for what we need tomorrow, which is really about a risk-based system and how do we calibrate for future potential threats there.
Great. If I could just build on the opening remarks, very productive from Julie and Esther. This system that bridges from science to society, I think thinking about it holistically and all of the component parts that need to come together in order to have an effective preparedness posture, I think that's what we all are aiming for, to be able to respond as needed to these events, whether it's a pandemic, a fast pandemic like COVID, or a slow pandemic like AMR. I think the scale issue is significant. One of the frameworks that we've adopted at MITRE is to really recognize that we have to speak 3 languages simultaneously when we're talking about this. The first, of course, and where we're focused is on health and public health and global health. But also recognizing clearly, as this event, COVID-19 has demonstrated, these are national security issues. These are economic security issues. And to ensure, I think this gets to the scale issue that Julie was thinking. I've been involved in global health security and pandemic preparedness for nearly 20 years. Arguably, the scale was off, potentially by an order of magnitude or more in the investments we needed to make in preparedness. I think now we have significant data sets to build the models and the justifications we need for the returns on those investments. The other thing I want to talk about, we're seeing the greatest buildup of capacity, of global capacity. Esther spoke about that for testing and obviously for diagnostics, that's true, but also for vaccine manufacturing. We're seeing the largest buildup of vaccine manufacturing in the history of the world. The question is on sustainability. So as we're thinking about the system and we think about the space, the facilities, the staff, the workforce that needs to be built and trained, and the stuff, the supply chains. How do we sustain the system is one of the greatest challenges we're going to face going forward. Because yes, this is a catalytic moment, but I think we're all we know too much, and we've seen the complacency that follows events like this, even like this, I would say. And so maintaining the capacities and continuing to drive innovation, just not at the lab level, but at the industrial base level, so that we have the speed and the scale that we need to deliver for all who are in need of these assets, of these products, in the time when they need them.
I was terrified by Julie's comment that the science is with us. I'm grateful for that, but that society may not be quite so with us. And this ties in the comment you just made. The Monique about investment. If we don't have society with us, then in democracies we may not get the resources we need for this task. Thinking about the Pasteur Act, which I think will go a very long way to a sustainable system for antibacterial innovation for the drugs and vaccines we need. It cost about the same as one Starbucks latte per year per American. That would be the cost of the U.S. government. And so we're having, are we able to convince the country that one latte a year is a reasonable investment to prevent what we know is coming with antimicrobial resistance. So, do we have any of you have better ways of thinking about this or better ways out of this box?
You know, I've been privileged to co-chair the CSIS Commission on Strengthening America's Health Security. We issued a report in November of 2019 that was basically entitled Ending the Cycle of Crisis to Complacency. And it really tried to address the issue that in the middle of a crisis, we are willing to spend more than a latte per American to get ourselves out of a big mess. But we don't seem to be willing to sustain that investment to continuously, in a progressive manner, enhance our own health preparedness and prevention, but also that of the people around the world that we depend on to have similar capacities in place, as Esther already pointed out. So, you know, it is a mindset. I think there are some structural issues that also need to be addressed. Just thinking from kind of the global perspective, the financing for all of this is a struggle, even for wealthy nations who have to balance their budget every year. But broadly speaking, when you're responsible for your country's budget and you're looking at an array of competing priorities, prioritizing something that might happen necessarily falls to the end of the queue all too often. I wish we could easily learn the lesson that, you know, just because something is not predicted, it doesn't mean that it's not predictable and likely. But nevertheless, we really struggle to do that. So I think we really have to think differently about the financing mechanisms and creating a global finance facility that extends the global health security agenda beyond where it exists today. But even in the United States, we need structural changes in how we fund public health. That annual budget cycle doesn't work because things don't score well when you're trying to balance the budget, because much of what we invest in this year does not pay off this year. It doesn't pay off for years down the road, and yet it definitely does pay off, as we've just seen. So we have to have some very serious conversations. And you know, one mental model that I think fits really well with antimicrobial resistance, as well as the emerging threats that spill over and cause sudden outbreak situations. I think the mental model really needs to be health security, and that we think of it in the same pillar of investment that we think of as national security. Most countries understand their national security. They understand that's a fundamental responsibility of government, and they're willing to pay for it. I think we have to get ourselves committed to the fact that what we're talking about today with AMR and emerging infectious disease threats, that these are also elements of national security, and they need to be considered in the same framework, not necessarily the same department or, you know, the same structural execution component of government, but the same kind of investment with the same anticipatory. I think we were talking in the earlier panel about insurance. And in a sense, this is a form of health insurance that has been woefully undersupported. And somehow that conversation needs to really take on a renewed energy in the aftermath of what we're experiencing right now. And that probably needs to start now, not in the true aftermath, because by then we would be at risk of tipping back into our, as usual, complacent mode.
Yeah, I mean, I think those are great points. And I jotted down that comment around public health insurance as well from the earlier conversation. You know, we do have this cycle, right, of collective amnesia once we've gotten past the crisis. And we are, as a collective society, at risk of doing it again, though, hopefully, with the tragedy of COVID-19, we're less likely. We mean 700,000 deaths in the US, over 4 million around the world. If that's not a call to action, I'm not quite sure what will be a call to action. So now is certainly the time. But when we think about preparedness, we see a lot of initiatives that are springing up, which have the potential for continuing the same cycle that we've dealt with before. Institutions come up with their initiatives and governments come up with their initiatives, but there's no harmonization of those initiatives that really get us further down the field. Now, that being said, we do have very strong institutions that need to be built upon from a preparedness perspective, but I think harmonization is going to be key. One of the things that we've been working on over the last, I would say about 12 months or so, is bringing together experts toward a vision of an early warning system. So there are three areas that we can think about this: early warning, surveillance, and response. And we certainly see a lot of attention right now in terms of the response to COVID-19, appropriately so. Surveillance, we have infrastructure institutions around that for event-based surveillance and influenza and other infectious diseases that we know. Where we have a gap, and I think AMR can fit there into this category, is that early warning. What can we start to identify where all the confluences of the factors come together? You have the ecological changes, you have human changes in human behavior, you have migration, you have zoonotic potential for zoonotic spillover, livestock and human behavior. Where can we use different strategies to look at both traditional data and non-traditional data to identify potential risks and hotspots where these spillover events could occur? And that's an area that we've been quite focused, working in partnership with the Rockefeller Foundation, to say, can we envision an early warning system that could alert us to the potential for this risk? Obviously, such a system needs to be built on existing infrastructure and local health systems where it's relevant. You don't want an alert system that only gives you information every 7 to 10 years. You want something that is relevant to those local contexts on the ground. And I think as we think about what this entails and takes, we have to think about value in a two-directional means. Value back to those countries, value back to those local communities providing data, but certainly value that could be utilized at a global level as well. We have those opportunities now, but coming together to identify what is the minimum core data that we need to share. How do we share that information? What risks do we want to quantify? What data could be utilized in a de-identified way? Protecting privacy and protecting national sovereignty are all key considerations. AMR can fit into that picture, absolutely, but I think we need to weave all of this together to have a unified and harmonized approach, not necessarily just individual efforts, which I think, again, will get us back to where we've been before.
It's great.
Yeah, and I think that the early warning effort that you're doing with Rockefeller is incredibly important. I think, the work that we do at CARB-X, we also want to make sure that the drugs that are approved by the FDA and by EMA in a decade actually target the bacteria that will be emerging as the most dangerous ones in a decade. So early warning is for all sorts of response, including for drug developers to know where to go, as well as for every other element within the ecosystem to be able to respond. And Monique, I'm sorry, I think I cut you off there at the beginning.
No, that was important, Kevin. I want to follow up on three themes. One is governance, two is sort of the threat assessment, the threat domain, and three is this concept of insurance. I think when we think about innovation, we have to think about innovation and governance as well. How do we manage these complex ecosystems? How do we engage all of the appropriate performers and stakeholders in a meaningful way and in a sustained way? I think I was privileged to be part of the group that stood up ASPR and BARDA under Julie's leadership and General Russell and many other great leaders 20 years ago. Managing that ecosystem just across the US government was and remains a challenge. I think finding that collective purpose where you come together to mitigate risk is critically important. I think building accountability into that system, having meaningful measures is critical. I think that's one of the things. It's one thing not to be prepared. It's another thing not to know you're not prepared. And I think we've learned through this one that our assessments of where we stood with regard to being prepared as a nation in the US or globally through global health security and the indices that were developed fell short of expectations and didn't arguably drive the kind of action we needed. So I think governance is something, and accountability and meaningful measures is critical. With regard to threat assessment, I think this gets into how do we think about AMR in the context of COVID and in the context of chronic diseases or non-communicable diseases. I'm a big believer in there's multiple synergies here and that we have to avoid sort of a zero-sum calculus as to where we invest and find those opportunities for synergies, especially in the healthcare systems. And I speak of this in an integrated manner, both public health and the and the hospital systems, healthcare systems. So I think there's enormous opportunities, especially globally, to look at the infrastructure building, because I believe that's how you build trust, is by having a persistent presence and providing the services, the goods and services that the community needs. And I think whether that's antimicrobial resistance or an infectious disease outbreak, or the epidemic of cancer that is growing in lower and middle income countries, there are enormous opportunities to create that trust through persistent presence and provision of services. I do want us to think about reframing this concept of insurance, because when I think of insurance, I think about a piece of paper that sits in a safety deposit box. I like to think about what we need to do is building capability. It is a constant activity. It is not about signing a check. It is about, and I think lessons learned. I was one of the leaders in the Center for Innovation and Advanced Development and Manufacturing in North Carolina at Holly Springs. The concept of having that readily available facility that could manufacture a medical countermeasure against any threat known or unknown was a great concept. I think what we need work in globally is, what does that really look like for capacity building, capability building? How do we know that what we envisioned as that rapid response capability to manufacture a countermeasure really operates with the efficiencies, the speed that we need? The other thing that happens when we prepare and we think about the capabilities is we think about the specs. So again, it was remarkable what the scientific and biopharmaceutical industry delivered last year with the mRNA vaccines and other vaccines. However, the supply chain, the target product profile, if you will, the minus, the very cold chain demands of having to move these products really limited their ability to be used effectively. We would never design a target product profile that had that kind of storage, but you don't have that in the midst of the crisis. You don't have the luxury of doing formulation, building better formulations. So I think that's another, these investments in preparedness to get the types of products we want and being very specific about the products we want and looking for those synergies across the threat space is going to be critical as we move forward.
So there's go ahead.
I was just going to just reflect really quickly on one of the points that Monique raised. I thought it was a very important point about not having an insurance document that you put in the safe deposit box and you wait until you have that accident, if you will. And it reminded me of a lesson learned here in the US system in terms of standing up clinical trials for COVID-19 quickly. We did not have a clinical trial enterprise that was standing ready to respond to a pathogen or a pandemic of this size and proportion. And certainly NIH and many others pulled together networks through Active and other collaborations in order to conduct these clinical trials. And what we found out is that we have clinical trial infrastructure in academic settings that are on the East and West Coast and fairly limited in the rest of the country, but where you saw patients were in the communities, right? We did not have them tied back into that infrastructure. And so when we think about this post-pandemic world and how do we prepare for the next, it's about how do we bring together an ecosystem where you can keep warm by practicing on endemic diseases, chronic conditions, oncology, other conditions that are triggering and happening in the community, so that you have those relationships built, you have the infrastructure built, and you're better able to respond. That is certainly what we saw differently in the UK's response. If we think about that analogy, what we're talking about with preparedness, it's really about what are the ongoing activities that add value back to those local systems, where it provides information now, but can be leveraged in the future when there is an outbreak.
Exactly. And I think getting those measures that demonstrate that value across the ecosystem, not just for a particular AMR or COVID, but I think that will build credibility and confidence about moving in the right direction.
So an example that works for the world, I mean, just think about fire protection. I mean, for cities, fire was the enemy for millennia until about 100 years ago, when cities started to do a better job on organizing fire protection, to have hydrants and trained individuals and fire trucks and hoses and then eventually, prevention sprinklers within buildings. That's an investment to prevent something. And you don't wait until the fire is going before you think about designing your first fire truck. It's ready and the whole team is trained and the infrastructure is there. We've done that really well, to the point where, the fire departments, spend most of their time now on thinking about prevention as opposed to responding to actual fires, which is a good thing. It's sustainable. And so we have a moment right now. There's legislation moving forward in the U.S. Congress. The comment earlier about standing up, the Assistant Secretary for Preparedness and Response in the U.S. 20 years ago. Thank goodness, a lot of the funding for R&D for antibiotics comes through ASPR and BARDA. It's a leader around the world in this effort. So there's legislation on pandemic preparedness moving forward in the U.S. It's in the House Energy and Commerce Committee and in the Senate Health Committee. What can we do in the U.S. to really match what others are doing, United Kingdom and European Commission and Japan in this area? And we have about 5 minutes left, so jump in and have at it.
Well, I'm happy to jump in. I was waiting patiently for others to comment as well. So, the US is obviously a leader, and among others, the UK as well. We just recently heard of the WHO hub that was announced in Berlin for pandemic and epidemic intelligence. Those are good initiatives that are being stood up, the UK pandemic radar, certainly. And as I think about the future, it is important to have that level of leadership, but we must not neglect the rest of the world and bringing them to the fore of being part of designing the system that works for them. We think about the emerging infectious diseases, 70% of those diseases are likely not going to be happening in North America or in Western Europe. So what do we need to do to ensure that G20 countries and others have a very prominent seat at the table to identify what priorities matter to them in that design of the future? Of course, we're very encouraged to see the CDC forecasting center that's being stood up. I think that's certainly a great initiative as well. But there is a little bit of going backwards and thinking about the assets that already sit within country and building that capacity, doing that workforce training and investment, providing that genomics capability at the appropriate levels. The data analysis cannot sit so far removed from the context in which that data was generated, where it's meaningless and useless in that local context. So having this bi-directional share of information, I think, is going to be critical, and linking it up to these very important initiatives. And certainly the capacity building is one that we cannot underestimate, how much manpower and resources it's going to take. Again, that's relevant to the conditions on the ground. It was interesting, we were in a conversation not long ago in one of our work group conversations on this topic, and one researcher in a country said they learned about an outbreak in their country from a news report in the United States, and were not notified first as courtesy that this was going to be provided publicly. Right. And so we can't make those kinds of mistakes when we talk about maintaining trust and asking for data to be shared. That data cannot be to the benefit of just one part of the world. It has to be to the benefit of all the parties.
Yeah, I think one of the things on the topic of antimicrobial resistance is that, for those of us who are sort of in the choir, we understand the similarity in the relationship, that these are all part of a common problem. But it's hard, I think, in the minds of most people to put drug-resistant bacteria into the same category as SARS-CoV-2. And somehow we have to take advantage of this teachable moment. That's why I was really interested in Michael's experiences and what the CDC knows about the incredible utilization of antibiotics in the inpatient setting as a consequence of the prolonged hospitalization and nosocomial complications of COVID. but also what that has done to the prevalence of multi-drug resistant infections in the healthcare setting. Of course, it's been offset by less antibiotic use in outpatients because people aren't getting care for common problems, or possibly aren't getting common infectious diseases as likely as they did in the past. But, I think on a global basis, I don't have data, but I'm just guessing that if we polled citizens of the world about where they currently rank the problem of bacterial infection resistance, it would not be very high on the radar screen. And yet, if you actually look at the threat that's most likely to affect the largest number of people over an arc of time, it's going to be AMR. So, we do really need to try to bring that conversation into focus. And if we create systems that monitor the spread of drug-resistant infectious diseases, that also strengthens our public health system and will inevitably strengthen our overall preparedness infrastructure for public health. It's kind of that notion of dual purpose. But I'm ruthlessly willing to exploit the attention that the pandemic is creating to generalize that investment to cover the broader range of infectious disease challenges that we're facing. And I'm not shy about admitting that's very much a strategic positioning. But I also think, when we look at the global fund to industry investment with private and public partners in the AMR fund, we're putting skin in the game, but we still have to solve for the ability to make those investments actually operate at a country level. So we have a lot of work to do in this regard.
Yeah, I don't want to understate the challenge before us, but I think the opportunity is significant. And I agree with Julie, it's not obvious to all, or even to many perhaps, but this is a teachable moment. And I sign up to be one of the ruthlessly willing to try and bridge those communities and continue to demonstrate the efficiencies and the opportunities that are offered by thinking about this more holistically. It reminds me sort of some learnings from when I went to Sloan and was working with Professor Andrew Lowe on the concept of a mega fund. And what you want to do when you're designing a fund is you want to have uncorrelated assets. So in a way, from a financial perspective, there is value in the diversification of a pool of assets that perhaps is not only targeted to a single threat, but might actually have a broader profile. That might be a little not talk about non-obvious, but I think there's lessons to be learned from pooling uncorrelated assets from a financial perspective that are worth thinking about. I know we wanted to focus it, and we were going to end on a high and positive note, but I think what's important, we referred to the influx. There's enormous energy and influx of people that are now thinking about around the world that are thinking about these challenges. I think it's incumbent on us, with all of this energy and this infusion of talent, is to ensure that we also don't repeat the mistakes of the past, and truly have learned from years, if not decades, of investment in the space, the things that really worked and the things that did not work so well. I think it is worth thinking about, the emergence of SARS in 2003 and MERS in 2012. And the research community did phenomenal, undoubtedly, in helping us prepare for the antigen that we then needed to protect ourselves against in SARS-CoV-2. But again, I think thinking about speed and scale and how we sustain that is going to be the challenge of our time. Is sustaining the investment, sustaining the attention, and engaging the public. We are at risk of collective amnesia, but we've had a collective trauma as well. And so the want to put it in the rearview mirror and move forward is going to be powerful. And I think it's incumbent upon us as folks that have been dedicating much of our careers to think about how to bring the public along. Because again, this won't work without public engagement and public trust.
I feel like we almost need Hollywood or New York advertising or executives, because nobody comes away from a house fire in which the fire department arrived and put out the fire, and the first thing out of their brain is, let's cut funding for fire departments. Preparedness is smart. Preparedness is cost efficient. It's really effective, and preparedness is our way to to continue to live the lives that we're hoping for as a global civilization, and getting that message appropriately out, getting our countries to take the legislative steps that are necessary, engaging the people so that democracies can lead in this effort, and the public actually sees the benefit, not just elites telling them about the benefit. These are our challenges, and I have to say it's been an enormous privilege to learn from these two panels today. It's morning for me in Boston, so I've started my day right. I really want to thank everyone for your time, and we're at the end. I don't know, Ken, if you have a parting word or if I'm just signing off and saying goodbye, but thank you for everyone for tuning in, and we hope that this has been as good of a session for you as it has been for me to learn and to listen to these wonderful panelists. Ken?
No, again, thanks, Kevin, for moderating it. I mean, I think the two sessions were outstanding. Again, I love the international perspective on this. Let's just keep up the dialogue. Lots of work to do, and we really need to figure out, in terms of investments, how we build a public health infrastructure that really is agile, that anticipates the next set of unknown pandemics. So I think we had a lot of good ideas, and I appreciate everybody for taking some time this morning, afternoon, and evening to share with us.